I'm Fabiola, a fifth-year medical student, and I'm going to be talking to you about Huntington disease, or as it's sometimes known, Huntington chorea. So first of all, some background. Huntington generally involves cerebral atrophy starting in the basal ganglia, and it particularly affects any cells which are involved in glutamate or dopamine neurotransmission. So the atrophy is particularly marked in the neostriatum, in the caudate nucleus and the putamen. Some atrophy can also be seen in the deep layers of the cerebral cortex, although other areas may also show some atrophy depending on the grade. So cerebral atrophy is graded from 0 to 4, and the overall progression of the actual disease is staged from 1 to 5. So you can basically split the Huntington symptoms into 3 areas: movement disorders, cognitive disorders, and behavioral changes or psychiatric disorders. So first of all, in the movement disorders we have chorea, which comes from the Greek word to dance, as in choreography. So chorea is basically any involuntary movement from fidgeting to flailing towards the end stages of the disease. Something else that's quite common is problems around the mouth and the throat, usually resulting in dysarthria or difficulty speaking, and dysphagia or difficulty swallowing. Towards the end of the disease, the patient may also encounter more Parkinsonian features. They may encounter bradykinesia, so they're moving more slowly than they'd like, and rigidity inside their limbs. Huntington also often presents with a variety of cognitive disorders. The patient may have problems with memory and attention and any kind of reasoning. In terms of behavioral changes, depression is quite common, although it's difficult to tell whether this is due to the disease or due to the knowledge that they have a progressive illness. Other disorders such as bipolar and obsessive-compulsive have also been noted in patients. So remember, staged 1 to 5 and graded 0 to 4. So stage 1 is basically early disease, so it will be from 0 to 8 years after disease onset. The patient will be fully functional and they might have some very mild cognitive and behavioral changes. Stage 2, we have early intermediate, that's 3 to 13 years after disease onset. And sometimes they may not be able to work at this point and they're going to need a lot of assistance in at least one basic daily function. Then we have late intermediate, which is 5 to 16 years. And at this point, the patient unfortunately will not be able to work at all and will need assistance in most basic functions. Then we have stage 4, which is early advanced, or 9 to 21 years after the disease onset. At this point, they will unfortunately need significant help in all areas of life. They may be able to remain at home, albeit with some help. At stage 5 or advanced disease, they will need full-time care. So this is usually the point at which they will need to be moved to a facility or the family will need to hire a full-time nurse. And the normal life expectancy can vary from anything from 10 years to 25 years after symptoms begin. And the cause of death is often, unfortunately, due to a complication. So while you may not die from the brain atrophy, not being able to swallow properly or breathe properly might, for example, lead to pneumonia. Let's move on to grading. So grade 0 means there's no sign of atrophy at all. Grade 1 means there's some microscopic changes, but no gross atrophy or no gross visible changes. At grade 2, you might see some atrophy around the striatal region, but the caudate nucleus still looks as it did before. At grade 3, there's severe striatal atrophy, and the caudate nucleus will be flatter. And then at grade 4, when you have very severe striatal atrophy, the caudate nucleus will be concave. So to make things slightly clearer, here are some pictures of a patient's brain, and you can see quite clearly how the ventricles at the centre look a lot wider, and they've lost a lot of the shape around the sides. You can also kind of see the atrophy all around the edge of the brain. Okay, let's talk about a case. So, a patient known only as 13 walks into your clinic. She is a 30-year-old female, and she's just noticed that she's been a bit clumsy lately and a bit forgetful, and apparently she's had a couple of mood swings. And as an autosomal dominant condition, one of your biggest clues here will be the family history. If your patient has it, one of her parents probably has it as well. If both of her parents are in good health, it's less likely to be Huntington. It shouldn't be ruled out though, because first of all, it is possible that one of the parents will develop it later on in life, and it is also possible that it is a new mutation in her. Speaking of age of onset, normally Huntington presents between 35 and 44, but this can vary a lot. Technically, people have developed Huntington anywhere from after the age of 2 to their 80s. Something called the Westphal variant is basically juvenile Huntington disease, and this is where anyone under the age of 20 begins showing symptoms of Huntington. So to diagnose it, we use genetic testing. Now, Huntington results from a mutation on chromosome 4 on the Huntington gene, or HTT. So we're looking for CAG repeats. Anything over 35 means it's a positive test. Anything less than 26 rules it out completely. As said before, there are possible reasons why a patient's parents might not seem to have it. It may develop later. And of course, there is the possibility that they aren't the biological parents. Also, if the patient has a family history but no symptoms at all, it may still be a good idea to do some genetic testing. First of all, to see whether they have the gene that would suggest they will develop it later, but also to anticipate how soon they might get it. Generally speaking, the more CAG repeats there are on the Huntington gene, the earlier onset the disease will be. Having said this, if a patient has a strong family history of Huntington and they are showing signs themselves, it's not always necessary to do genetic testing. A CT or an MRI can be used to measure the bicaudate diameter, so we're basically measuring the caudate nucleus inside the brain, and this can be a pretty good marker showing how far the disease has progressed. So the focus when treating a patient with Huntington is to treat their symptoms. So monoamine inhibitors and anticonvulsants can be used to reduce chorea. For example, tetrabenazine, which is a monoamine inhibitor, and clonazepam, which is an anticonvulsant. Antipsychotics can be useful, such as haloperidol, and antidepressants, such as SSRIs, for example, paroxetine. Okay, let's do some questions. Remember our patient 13? What stage do we think she was most likely to be? The answer is stage 1. Remember, staging goes 1 to 5 and grading goes 0 to 4. Question 2. Where in the brain can you find the caudate nucleus? And the answer is in the neostriatum, which is in the basal ganglia. So here's a summary just to outline how Huntington works, how it's diagnosed. I hope this was useful. Please subscribe.